Hello and welcome to Best of the Day once more from the 50th annual meeting of the American Society of Clinical Oncology, once again at McCormick Place in Chicago. So this afternoon we're meeting with a number of experts in the fields of hematologic and solid tumors, and right now I'm very happy to be sitting down with Dr. Ruth O'Regan from Emory University to talk about breast cancer and what's been going on. This was a fairly big year for breast cancer. 2 out of the 4 plenary session abstracts were on breast cancer, some long-awaited trials. So we're happy to talk about those and some of the exciting newer agents coming along, and a few trials that turned out to be disappointing. So Ruth, welcome once again to Best of the Day for the 854th time.
Thank you for having me, as always.
So why don't we start off with Alto? And Alto was late-breaking abstract number 4. This was an adjuvant trial in HER2 overexpressed patients, looking at whether or not there would be improvement over trastuzumab alone, lapatinib alone, trastuzumab followed by lapatinib, or trastuzumab plus lapatinib. And of course, everybody also got chemotherapy, whether it was an anthracycline or taxane-based or even a cisplatin regimen. I know the lapatinib arm was closed early for futility, but how did things work out with the other 3 arms, and are there take-home lessons from this?
Yeah, so I think it was somewhat of a complicated trial design because, you know, the Europeans wanted the chemo to be given sequentially with the HER2-directed agents, and then the US, we wanted to give them together. So it was a very large trial because of all the connotations that were going on in terms of what patients were getting. But as you said, essentially it was comparing trastuzumab to lapatinib followed by trastuzumab, or to the combination of the two. And as you well remember, Alto had shown a very nice signal showing that the combination of trastuzumab and lapatinib actually resulted in a higher pathologic complete response rate than either trastuzumab alone or lapatinib alone. So we were all very excited about this trial, but unfortunately, you know, it was a negative trial. Overall, the event rate was probably lower than what we expected, but there was really no difference between the arms, and really not any signal in any of the subgrouping they looked at really to suggest that there was a benefit of adding in lapatinib with trastuzumab. And of course, on top of that, you have the issue that lapatinib is quite toxic, and there was a very high rate of diarrhea in the patients who got lapatinib, whether they got it with trastuzumab or indeed in the single agent arm. They did not report the single agent arm. That will be reported at San Antonio, but as you mentioned, it was closed for futility, so we're not holding our breath on that.
So did the presenter or the discussant, or, you know, in talking to other people, has anyone speculated on why the combination was so successful in the neoadjuvant state, where there's a lot of tumor bulk to try to reduce, whereas in the adjuvant state with minimal micrometastatic disease lurking out there, the combination added toxicity but no obvious benefit?
So it wasn't, nobody really kind of honed on what the reason for that was, but what I would say is most likely is it's the real issue of estrogen receptor. Because we now know that HER2-positive cancers that are also estrogen receptor are incredibly heterogeneous. In fact, Lisa Carey presented more data from their trial that was very similar to Alto, where they did intrinsic subtyping on the HER2-positive cancers before they got the chemotherapy.
So these are luminal Bs?
Well, so what they showed, and they showed this before, was that if you look at the HER2-positive, hormone receptor-positive cancers, about 45 to 50% of them are luminal B, but very interestingly, between 30 to 40% of them are luminal A. Now, luminal A cancers are, of course, driven by estrogen receptor, and we know they have a very low pathologic complete response rate, although in the study that Lisa showed, there was a reasonable pathologic complete response rate in the luminal A phenotype. So I think that's what's going on here, because if you look at the meta-analysis that was published looking at pathologic complete response as a predictor for outcome, What they found was that although pathologic complete response rate was predictive of outcome for HER2 positive, ER positive cancers, the hazard ratio was much less impressive than it was in the HER2 positive, ER negative cancers. Now, going back to Alto, I think if I remember rightly, about 60% of patients on that trial had ER positive cancers that were also HER2 positive. So I think overall, that's probably what's going on here. And I think that's a group that we've kind of ignored a lot, in terms of thinking whether they're different than, truly different than HER2 positive, ER negative cancers. And I think we need to look at them in much more detail because they're heterogeneous.
Yeah.
This is the problem. There's a group in there that probably may not even need chemotherapy, and maybe actually blocking estrogen receptor and HER2 is the best way to treat those cancers. And I really think that we need to address that in trials, because the way things are going in HER2 positive cancer is we're adding more and more expensive agents in to try and improve outcome for these patients, whereas I think there's a group that we may need to kind of pull back, and maybe we don't need to treat as aggressively.
So there was another trial, speaking of HER2 positive, and this was a retrospective look back at some of the adjuvant trials on the value of adding trastuzumab to smaller tumors that are T1As, 1Bs, and 1Cs that were 2 centimeters or less. Is it worthwhile to give them trastuzumab, added cost, potential added cardiotoxicity and other things, or does it make that much difference? And when they went back and looked at all these studies and the patients, what did they conclude?
Yeah, so this meta-analysis was actually presented in a slightly different form at San Antonio as well. And what they did was they took really all of the adjuvant trials that were done and kind of put them all together and tried to see what was going on with the smaller cancers. Now, interestingly, they included not just node negative, but also node positive, at least one positive lymph node in the analysis, which kind of muddies the water a little bit. And the other drawback is that there wasn't very many T1A and T1B cancers because, of course, they weren't included in those trials. But overall, the addition of trastuzumab to chemotherapy really resulted in very favorable outcome. And the conclusion, at least at the San Antonio meeting, was that there's a group of these cancers that we probably don't need to be adding some of the newer HER2-directed agents in. In other words, the patients do so well anyway that you really don't need to be looking at trying to improve on what you have already. And I will say, when you look at Alto as well, George Sledge was a discussant, and he was pointing out it was a negative trial. But what's remarkable to me is how well these patients do. I mean, most of these patients appear to be cured. So I think it's a huge success story. And obviously you always want to do better, but I think there's probably areas of greater need in breast cancer than perhaps just focusing on trying to improve what's already a very good outcome.
So over these past 10 years that we've been doing Best of the Days, both here and sometimes at San Antonio, we talked a lot about all the randomized trials comparing aromatase inhibitors with tamoxifen, mostly in postmenopausal women, and it was sort of assumed that in premenopausal women that you really needed to use tamoxifen. But the question of whether or not you could still use an aromatase inhibitor by adding, by shutting the ovaries down, whether it be by an oophorectomy or radiation or an LHRH agonist. So this year at the plenary session, finally, the results of the SOFT and TEXT trials were presented. So tell us a little bit about the structure of those trials, what the goals were, and what they found and what you take away from this.
Yeah. So just a slightly different design. So the SOFT trial is a 3-arm trial where these are all obviously for premenopausal patients with estrogen receptor positive breast cancer. The 3 arms were tamoxifen alone for 5 years, tamoxifen plus ovarian suppression, or exemestane plus ovarian suppression. And again, as you alluded to, you could do it by an LHRH agonist or radiation or oophorectomy. The TEXT trial, there was no arm that didn't get ovarian suppression, so it was basically tamoxifen plus ovarian suppression versus exemestane plus ovarian suppression. So there is an amendment of the trials a few years ago where they basically decided to do a joint analysis of the 2 similar arms in the study. So basically what we had at this meeting is an analysis of a large number of patients who either got exemestane plus ovarian suppression or tamoxifen plus ovarian suppression. And what was interesting is the results were almost identical to what we saw in the postmenopausal patients. So in other words, the patients who got exemestane plus ovarian suppression had about a 4% better disease-free survival compared to the patients who got tamoxifen plus ovarian suppression. So it was striking that they were so similar, in fact. Now, of course, the cost of this is toxicity, and certainly in my experience, younger women find it very difficult to tolerate ovarian suppression, so that is a big issue. And there was more patients that came off the exemestane arm compared to the tamoxifen arm, and it was like 16% versus 11% or something. And that's the last thing you want to see, because you really want these patients to take the drugs. The other problem is that they did not report the tamoxifen alone arm in the soft study. And it's possible that maybe that arm will not be inferior to tamoxifen plus ovarian suppression. And until we get that data, I'm not really sure if I'm ready to go in, on Tuesday morning and start recommending this to all my patients.
And so the tamoxifen alone arm is 5 years?
5 years.
And
they were all 5 years.
We already had the results of ATOM and ATLAS telling us 10 years is better than 5 years. And there's studies looking at tamoxifen for 3 to 5 years, followed by an aromatase inhibitor like letrozole for 5 years. So how do docs make the decision as to what to do with all these various options?
Yeah, I mean, it's a very difficult situation because we have no idea whether exemestane plus ovarian suppression for 5 years will be better than 10 years of tamoxifen. We just don't know at this time point. I think what would be helpful is if we have more molecular profiling to guide us. Hopefully we will see that from some of these studies to try and indicate, is it patients with low recurrence scores that do better with the ovarian suppression, or luminal A's versus luminal B's. And in the extended adjuvant setting, there is obviously the breast cancer index that is available now that is quite helpful in determining which patients should get 10 years versus 5 years of treatment. But I think it's very difficult, and I think it's going to be a very lengthy discussion with patients. But and Dr. Davidson, who was the discussant, I think overall her conclusion was maybe not quite ready for prime time.
Is obesity a factor in responsiveness to tamoxifen or the aromatase inhibitors? There's been a lot of discussion about obesity being a negative prognostic factor in certain breast cancer groups. And are there any problems with drug distribution in larger patients? So
there is some older data basically suggesting that aromatase inhibitors are less effective in obese women compared to normal weight women. I'm not aware of the same data with tamoxifen, but that of course is one of the questions that's out there, in terms of, because we had an abstract which looked at the early breast cancer trialist group, specifically premenopausal patients with estrogen receptor positive breast cancer, and they found that the patients who were obese had a significantly higher recurrence rate than the patients that were normal weight. And obviously that, because they're premenopausal, they wouldn't have been getting aromatase inhibitors. That doesn't explain that, but that would suggest that maybe there is a problem with tamoxifen metabolism based on body weight that maybe we haven't noted before.
And a quick stroll through almost any American city, and probably a growing number of European cities as well, tells you what a big problem obesity is in younger women. I mean, it's 30–40%. So I think that type of data is going to be really critical and really important.
No, absolutely. What was interesting about that analysis was that they actually didn't find the same in postmenopausal women, even though that has been shown before. And it made, I guess our hypothesis in postmenopausal women is that you're getting more estrogen production because of the aromatization occurring in the adipose tissue. But that doesn't explain premenopausal patients. So overall, I think the take-home message is, like for all your health, maintain a healthy body weight.
Yeah. Get out and walk and cut out the pizza and the beer. All right, so let's move on. We want to talk about the POEM study, and this was in premenopausal patients, again with using an LHRH agonist, but these were ER-negative women. So this was an attempt to protect their ovaries from the effects of cytotoxic agents, and so allow them not to go into an early menopause. So Was this strategy effective, and did it have either a positive or a negative impact on disease-free survival?
So this was a really interesting trial, I think. So it was about relatively small, about 250 patients, and they were all getting Cytoxan-based chemotherapy. So what they did was half of them got Grazereland during the chemotherapy in an attempt to maintain ovarian function, and the other half did not. So they did find that ovarian function was less impacted in the patients who got Grazereland, a pretty significant difference. Also, more patients that got Grazereland were able to get pregnant later on. But the other thing that was really fascinating, because these were ER-negative cancers, as you mentioned, is that there was also a positive impact on disease-free survival, which was significant in the patients who got Grazereland compared to the patients who did not, and even a trend to an improved overall survival as well, which makes no sense, and it basically comes back to the whole issue we have that I just don't think we really understand very well the role that estrogen plays in breast cancer. It's just very confusing.
The most interesting part of that presentation, I think, was when someone from the audience asked how they knew when women were attempting pregnancy. Well, we asked them.
Yeah, but I think it's interesting because, for ER-negative breast cancers, obviously with the young patients coming in, this is always a big question. And, when they've got ER-negative cancers, they're probably going to be, once they hit 5 years, their likelihood of recurrence is not going to be very high. And, I think this is really important data. And I actually do think this is
especially if it's someone who's still in their childbearing years and they hope to survive this and enlarge their family. I think it's a really important thing.
Because, as you know, it's such a hard conversation when these young women come in. And what's surprising to me is I still have women come in to me and they've been told they should never get pregnant. Yeah. So I actually think that's probably practice changing. I think, I would actually consider doing that for patients with ER-negative cancers. For ER-positive, I just don't know that I would do it because I just don't know that the data supports that yet.
It's only going to be a period of perhaps 6 months of ovarian suppression. It's not going to be 3 or 4 years. So yeah, I think I think there's a real lesson there. So bevacizumab. There was a big adjuvant trial looking at bevacizumab in resected breast cancer, and we already know how successful bevacizumab has been in resected colorectal cancer, where the CO8 trial, NSABP, was a total flop. So does bevacizumab work in the adjuvant setting in breast cancer? There have been a number of trials already looking at this. I think Beatrice and Beth were studies that looked at this, and now this large trial here in the U.S.
It was a bad meeting for bevacizumab. That's what I would say for sure. So this was 5103, which was an adjuvant study, HER2 negative, where patients got either standard anthracycline taxane-based chemotherapy alone, or they got it in combination with bevacizumab just through the chemotherapy. And then there was a third arm where they got the bevacizumab with the chemotherapy and then got it, I think, for maybe 13 doses afterwards. And unfortunately, it was negative. Again, as we've seen with other adjuvant trials, the event rate was much lower than was predicted. But overall, no hint whatsoever of benefit from bevacizumab. And of course, there was more toxicity, and obviously the expense of the drug as well. So it really was a pretty negative trial.
So it seems like there are a number of malignancies in which bevacizumab really helps facilitate the efficacy of cytotoxic chemotherapy in the metastatic state. But when you've got micrometastatic disease, it doesn't really seem to do a whole lot as far as preventing growth and expansion of micrometastases. And you kind of wonder how much the effect is on vascularization of these small metastatic lesions.
And it's interesting because initially when that whole idea of anti-angiogenesis came out, I think we all thought it was going to be much better on micrometastatic disease compared to macrometastatic disease. It's unfortunate, but as you alluded to, we had the Beatrice study in triple negative breast cancer was negative, the BET study in the HER2 positive setting that was also negative. And then this study essentially, and then of course in the metastatic setting, we have obviously a lot of trials, none of which showed a survival advantage. Exactly, and we're still, we had the LEA study that was presented at San Antonio that basically looked at adding it to endocrine therapy. It was a negative study. There's a CLGB study that had a very similar design that we're waiting for the results on. And there actually was a second presentation that was kind of related to bevacizumab, which basically it was a metastatic study where they gave between 6 to 20 weeks of a taxane with bevacizumab. And then if the patients had stable disease, they randomized them to either stop the taxane and start endocrine therapy, but continue bevacizumab, or continue the taxane with bevacizumab. And the outcome was exactly the same in both arms. So I think, the discussant actually made a very good point, because if the LEA study shows that bevacizumab doesn't add anything, at least that trial, I think it was called the Arrow-based trial, actually supports what most of us do for ER-positive metastatic breast cancer, where if we're going to give chemo, we give it for whatever period of time and then transition into endocrine therapy. And that this trial at least showed that that's kind of made sense, I think.
That makes sense, yeah, that makes sense. All right, well, there are several new agents. I mean, in the last several years, we've been hearing about the CDK 4/6 inhibitor from Pfizer, palbociclib, I think it's called, something like that.
Palbo, it's just easier that way.
Yeah, Palbo. And then Novartis has an agent, LEE-01, I think, or 011, and then Lilly has an agent with about 8 numbers behind it, LY something. So what is the role of these cyclin CDK 4/6 inhibitors, and what is the science behind their use?
So the Pfizer one, as you mentioned, the Palbo is the furthest along in development. As you may remember, there was a very positive phase 2 trial in the first line setting where they added Palbo in with letrozole. There's been some follow-up with that trial where it's not quite as impressive, the difference in PFS, but it still is, pretty significant. So the randomized phase 3 trial is going to close probably in the next few weeks. That will probably lead to registration of that drug. What's interesting is it is the first line setting, because I always think that a lot of these agents tend to work better when you've got resistant tumors, but this drug clearly works in the first line setting. We don't know if it works in the second line, how well it works in the second and third line setting at this time point. But obviously there's a lot of interest in these agents. The Novartis one is supposed to be particularly potent, and then the Lilly one as well. So there was a couple of very early phase trials with these drugs at this meeting. The Lilly drug was given with fulvestrant. It was feasible, it seemed to be activity with that combination. But the other thing is that you're seeing is a combination of the CDK inhibitors with PI3 kinase inhibitors and also mTOR inhibitors. So there was a couple of early phase trials looking at the CDK inhibitors with some of the other Novartis PI3 kinase inhibitors, which again looked feasible. I'm not really sure what the rationale for combining them is. I don't know that there's a lot of preclinical data to recommend doing it.
Are they thinking that the CDK 4/6 is a resistance mechanism for hormonal therapy for patients who develop resistance to letrozole or anastrozole?
See, I think that's the big question, because the fact you saw such a positive signal in the first line setting would suggest almost the opposite. Because the control arm in that randomized phase 2 study, I think their progression-free survival was in the range of 7-8 months. So, they weren't all resistant cancers. Whereas I think the PI3 kinase pathway, it appears to become more important as you develop resistance. So that's why I'm saying I'm not sure what the rationale for doing that is.
Adding everolimus for that PI3 AKT mTOR pathway.
Yeah, because if you look at Bolero-2 and TAMRAD, if you look at the control arm in those studies, the PFS was very short, suggesting that you had a lot of resistant cancers in there. Personally, if you look at the preclinical data that's out there, it does appear that those pathways become important as resistance develops. So I guess if you combine the CDK inhibitor and the PI3 kinase inhibitor, maybe the thought is you're hitting the hormone sensitive and the hormone resistant.
Has to be some
tumors.
Synergistic mechanisms there. Very good. All right, I think there were a couple other things we wanted to talk about, and you mentioned before some of the immune pathways, and the whole field of both triple-negative breast cancer and HER2 overexpressed breast cancer, what immunity plays in this, and what the extracellular stroma plays in whether patients respond or don't respond, and what their long-term prognosis is. So I think Edith Perez had a presentation, and Lisa Carey also had a presentation looking at these situations. Can you tell us about those?
Yeah, so this kind of hit the press at San Antonio a bit because there was a lot of interest in these tumor-infiltrating lymphocytes and this whole immune phenotype, essentially. So what Dr. Perez presented was they went back to the adjuvant trastuzumab trial that was run out of the the NCCTG. And what they did was they found these 6 pathways that were all associated with immune phenotype that were expressed in about 50% of the cancers of the cancers from the patients that were enrolled in the trial. And what they found was that if you had this immune phenotype, you got a marked benefit from adding in trastuzumab with chemotherapy. But if you did not have the phenotype, which was about half the tumors, the trastuzumab didn't add anything to the chemotherapy. So it was really quite striking data. And of course, we don't know how trastuzumab works, and at least some of what it does is probably through an immune process. So I guess it kind of makes sense, but it definitely was very interesting, I think.
Is there any correlation between HER2 expression and the immune phenotype?
Again, I don't think we know that, apart from this data where they were showing that 50% of the cancers have this immune phenotype.
So how common pathologically do you see pretty significant infiltration of lymphocytes, CD4, CD8 lymphocytes in breast cancers? And is it more common in the triple-negative breast cancers, or more common in the hormone-sensitive breast cancers? And is that going to be a key factor in whether or not immune agents might possibly be beneficial? I mean, you think about all these immune checkpoint inhibitors that are being looked at now. Would they potentially have a role in a breast cancer that already has a significant population of tumor-infiltrating lymphocytes?
Well, it appears to be reasonably common, and interestingly, it's pretty common in triple-negative breast cancers. Now, what I don't know at this time point is whether that is the triple-negative breast cancers that have this immune phenotype, if they correlate with the Vanderbilt subtype. If you remember the Vanderbilt 6 subtypes of triple-negative breast cancer that they identified, there was one that was this immune modulatory subtype, which again, I think it probably made up maybe 20% of the triple-negative cancers that we're seeing. We don't know how much that correlates at this time point. The GEPAR-6 dose study, they did show some biomarker data from that. Now, just to remind you what that was, that was basically either patients with triple-negative breast cancer or HER2-positive breast cancer were enrolled in the study, and they were looking at adding carboplatin and bevacizumab in with, strangely enough, liposomal doxorubicin. I'm not really sure why they used that, and one of the taxanes, if I remember rightly. And what they presented at this meeting was cancers that had what they described as a lymphocyte predominant phenotype, essentially, which was defined as having more than 60% tumor-infiltrating lymphocytes in the cancer cells. And I think it was about half of them, if I remember rightly. But what they showed was in the triple-negative group on the trial, the pathologic complete response rate in these cancers that had this lymphocyte predominant phenotype was 74% in the arm where they got carboplatin and bevacizumab. It was really very high. But they didn't see the same in the HER2-positive cancer, so it was a little bit different than what Dr. Perez has shown, although two very, very different ways of looking at the immune
Interesting
phenotype.
observations, but still a lot to unravel.
A huge amount to unravel. But I do think, as you point out, the melanoma drugs that we have, there's clearly going to be a lot of interest in looking at some of these agents in these immune-related cancers,
they're
breast
definitely
cancers.
looking for biomarkers for which tumors are going to will respond to anti-PD-1 and anti-PD-L1. And PD-L1 expression seems to be somewhat helpful, but not completely predictive. Perhaps tumor-infiltrating lymphocyte populations will be another potential predictive biomarker.
Yeah, well, we can certainly hope so. And then, from Dr. Perez's presentation, she was actually looking at genes and specific immune pathways. So maybe that's what we need to be looking at. But I think it's very exciting, particularly the triple-negative area, because that's where we need the treatment, the therapies. We just don't have any good therapies for those patients, unfortunately.
Well, it appears that the years ahead are going to be perhaps a good deal more exciting for breast cancer docs and patients than the last few have been, when it seems like there just weren't a lot of new agents coming along. But now with these CDK inhibitors and PI3 kinase inhibitors and the possibility of immune therapeutic approaches, looks pretty interesting.
Oh, absolutely. I totally agree with you.
Well, Ruth, thank you so much. As always, as Brian Williams on NBC says, as always, it's so good to sit down and talk to you about breast cancer. And I appreciate your taking time before you head home to visit with us.
Well, thank you, Jim. It was
You
my
bet.
pleasure.
And thanks to all of you for watching this segment of Best of the Day from the 50th annual meeting of the American Society of Clinical Oncology. Stay with us. There's much more to come from this year's meeting. Thanks again.